All right, let's do another CCRN style question. We're going to be talking about heart failure and hemodynamics kind of at the same time with this one. So this is a 70-year-old patient with a history of ischemic cardiomyopathy, is admitted to the ICU with worsening shortness of breath and fatigue. PA catheter is placed and we get these hemodynamic values. So what I'll say about this is for the CCRN, you need to know both the indexed values as well as the normal values, right? So let's go through this really quick. And then we want to find the intervention that would be most appropriate to improve this patient's cardiac output. So that's what we're looking for in this, is something that can improve the patient's cardiac output. So our cardiac index is low at 1.7. We want it to be at least 2.2. Our wedge pressure is 26. This is basically like the CVP of the left side of the heart, our left-sided filling pressures. Normal is between 8 and 12. So this is extremely high. We have very high filling pressures on that left side. Our SVR is basically our afterload. Normal is between 800 and 1200 for the non-indexed value. This is 1600, so this is pretty high as well. Mixed venous oxygenation, 52%. This is basically how much oxygen the cells are pulling out of the blood before it comes back to the right side of the heart. We're looking at 60 to 80% for normal on this, so this is actually low as well. And this is probably because our cardiac index is low. And then blood pressure 92/58, which is pretty expected. So let's go through the answers and see which one we think is right. So first, administer a normal saline bolus. I think we can all agree that this is not the answer for sure. And because we have super high filling pressures on that left side, we're going to increase them if we give another saline bolus, and we're going to increase that congestion in the lungs. So not A. And then start a norepinephrine infusion. So with this, we're going to increase our SVR, and that's something that we really do not want to do at this point. It does have a little bit of beta agonism, so it might help inotropy a little bit, but not enough to overcome this SVR that we have, and we'll probably see the cardiac output actually go down. Administer IV furosemide. So this is Lasix, right? This is a diuretic. So if we give Lasix and we diurese before we do anything with the heart in order to help it in an inotropic fashion, right? We're going to decrease stroke volume without increasing inotropy. So we're going to see most likely either the cardiac index stay the same or actually go down because we're decreasing that stroke volume. So at this point, we would not give diuretics. If we were looking at maybe giving a dobutamine infusion in which we are actually increasing inotropy and decreasing our SVR because dobutamine is an inodilator, then this is something that we could see as increasing our cardiac index. We're decreasing our SVR while also increasing the inotropy of the heart. So we should be able to see a pretty substantial increase in our cardiac index with this medication.